Hello? Shall we start?
Yes, Suranga. Shall we start?
Yes. First speaker is there, so we can start it there. Good afternoon. Today is our Uromet 8 on female urology. It's opposite to the previous two sessions, and it is organized by the Education Committee of Sri Lanka Association of Urological Surgeons. And we have an expert panel from Neville Pereira from the Hospital of Sri Lanka, Dr. Anuruddha Begun from South Asian Hospital, Satish Edmusing from Rapidia, and Dr. Manjulu Vijayawardana from the Hospital of Sri Lanka, and the Suren Silva, and the Dr. Namadana from Colombo Teaching Hospital. And some will join me lately. We have 5 topics to discuss. First topic is female urinary incontinence, and done by Dr. Winder. He has 20 minutes, and the second speaker is bladder pain syndrome by Dr. Irina Samarasinghe, 10 minutes for him. And the third one is vesicovaginal fistula by Dr. Gihan Agalavatta. He has 10 minutes. And pelvic organ prolapse by Dr. Achyudan. He has 10 minutes. And urinary retention in women and urethra diverticulum by Dr. Milan Gunwardhan. He also has 10 minutes. And we expect you all will stick to your time frame, and we will indicate 5 minutes before you finish your presentation in 20 minutes speakers, and at 8 minutes for the 10-minute presentation. And without much time, I will invite Dr. PG and Govinda to present this presentation with female urinary incontinence. Over to you, Govinda.
Thank you, sir. Can you all see my slides, sir?
Yes.
Okay. Good evening and welcome to Uromet 8. I'm Dr. Nalin Palhipitiya, Senior Registrar Urology from Sri Javadhanpur Hospital, and I'll be talking about female urinary incontinence today. And to start with, urinary incontinence is increasingly recognized as a significant problem even by the WHO, and it has been acknowledged as a significant issue even by the WHO. And the prevalence of urinary incontinence ranges from about 10% to 60% worldwide, but for the Asia Pacific region, it is about 14.6%. The relative low incidence reported in Asia Pacific region is probably due to underreporting caused by embarrassing situations, and because it's seen as a social taboo. And though it is underreported even in Asia, about 16% of incontinent women and 20% of incontinent men were significantly bothered by their condition. But interestingly, about half of them only seek medical help as for the reasons I mentioned above. And the definition of incontinence is actually not well defined, but for a working diagnosis and for the discussion today, I'll be sticking on to the ICS definition, that is the International Continence Society definition, which says urinary incontinence is the involuntary loss of urine, which causes a social or hygienic problem, and it is objectively demonstrable. And to better understand the incontinence, we should have a little bit of recapitulation of the anatomy and physiology of the micturition. As you all know, the urinary tract has 2 main functions, the voiding function and the storage function. And this is achieved by a very complex neuromuscular coordination. And recapitulation of the bladder anatomy, it's a muscular membranous sac, and it has 4 layers. Out of them, the muscular layer is the most important one for us as urologists, and it is consistent of 3 main layers, which converge at the bladder neck and the ureteric orifices. And the normal bladder can distend up to about 500 milliliters without increasing the intracycle pressure, interestingly. And the female urethra, the anatomy wise, it is about 4 centimeters in length and is embedded in the anterior vaginal wall and has 3 muscular layers. The inner 2 muscular layers are actually a continuation of the detrusor muscles, and the outer muscle layer is a voluntary muscle fibers. And as seen in this picture, you can see 3 layers apart from the muscle layer. There is a mucosa, submucosa, and the muscle layer. And the most important physiological unit for the incontinence is the sphincter unit. And this consists of 3 main components: the internal sphincter, the external sphincter, and the pelvic floor muscles. The internal or the involuntary smooth muscle sphincter is a condensation of the detrusor muscle itself, and it is innervated by the sympathetic nervous system. And this is important to maintain the continence during the filling phase, and it remains closed during the filling phase. And the external sphincter is formed by voluntary striated muscles, and it is the primary continent mechanism in females. And the pelvic floor muscles support the continence by maintaining the bladder neck at the level above the urogenital diaphragm. And the relaxation of sphincter is voluntary, and it occurs in coordination with the detrusor muscle contraction during voiding phase. And the micturition reflex can be modulated by the voluntary contraction of the pelvic muscles as well. The innervation of the sphincteric unit and the lower urinary tract is by both somatic and autonomic systems, and the parasympathetic for the autonomic system is mainly by S2 to S4 segments of this S2 to S4 sacral segments, and the sympathetic innervation is from the spinal segments of T10 to L2 levels. And the somatic innervation is through the pudendal nerve, as you all know, and the nerve root levels are S2 to S3. And this is just a diagrammatic representation of the physiology and the physiology of the micturition and the micturition reflex. I will not go into detail because I have other more slides to discuss it. And just to talk about the development of the detrusor sphincteric muscle and the detrusor sphincteric coordination and the development of the continence. At birth, usually the bladder is not being controlled by the supratentorial segments. So usually it fills about for about 40 milliliters and periodically empties by the contractions according to the micturition reflex. But by the age of 2 years, there is myelination of the sensory and motor pathways, and by the age of 4 years, the brainstem reflexes are complete, and that so at this level, they learn to maintain the micturition in socially accepted condition. So from there onwards, in a sequential manner, the child learns to control the micturition and maintain the continence during life. And usually, to discuss about the urinary incontinence, we should first classify incontinence. Usually, it is basically divided into 2 types: the transient incontinence and the genuine or true incontinence. The transient incontinence is important because it is a treatable condition. So usually occurs in infection when there's endocrine issues or if there is stool infection commonly. And all these causes are reversible causes, so that if we treat it properly, the patient will come out of incontinence. And the topic here today to discuss is the true or genuine incontinence. And there are about 6 subtypes of genuine incontinence, including stress incontinence, urge incontinence, overflow incontinence, functional incontinence, and total and mixed incontinence. The stress incontinence is the most common among Paris women due to pelvic floor dysfunction and urethral hypermobility. And this is the most common mechanism occurs in stress incontinence is the displacement of urethra and bladder neck downwards and away from its retropubic position. And this is partly caused by declining estrogen levels following the menopause, and other causes like pelvic surgery causing denervation of the pelvis and irradiation also are mentioned as causes for stress incontinence. Overflow incontinence occurs when there's elevated intravesical pressure that overcomes the urethral resistance, so that in the absence of detrose activity, there is loss of urine. So it occurs usually in two situations, commonly in bladder outflow obstructions. In men, it's commonly seen in benign prostatic hyperplasia, and women almost always with urethral stenosis. And the second situation where overflow incontinence occurs is the atonic bladder, usually caused by diabetic autoneuropathy and spinal trauma. And the classic symptom in overflow incontinence is nocturnal enuresis, as you know. And this can be further subdivided according to the urodynamic studies as high pressure, low flow systems and low pressure, low flow systems. But out of these, high pressure, low flow systems are the dangerous situations where you should act promptly. Urge incontinence is the incontinence preceded by strong desire to void, and it is usually followed by a long history of overactive bladder. And the classic thing seen in urge incontinence is that there is detrusor instability or detrusor hyperreflexia. And detrusor hyperreflexia is usually associated with poor bladder compliance, so that they have a higher risk of developing upper tract reflux causing nephropathy. Reflex incontinence you almost always occur in paraplegic patients where there is the bladder takes up into its initial neurological status where there is no upper tract inhibition, so that the bladder acts in a micturition reflex level only. This is usually seen in paraplegic patients. And the last type of incontinence I would be discussing is the total incontinence. It usually occurs in two situations in women. That is, the first one is congenital lower tract anomalies, like in ectopic urethral insertion. And most common one would be the post-surgical, that is what we find in this vesicovaginal or ureterovaginal fistulae. So when we get a patient who complains of incontinence, usually a female one, the clinical assessment starts with proper history. And in the history, we should always ask about the duration, circumstances, the voiding symptoms, and storage symptoms. Apart from that, the past surgical history, most importantly, the gynecological and birth history should also be considered in. Physical examination is the usual way, but make sure that you go through all these P's, the 5 P's, palpable bladder, pelvis, the vulva to see whether there's prolapse. Do not forget to do a per-vaginal and per-rectal examination and a peripheral neurological examination. And the most important segment of this talk is investigating incontinence. So I'll be dividing that into 3 major components: the simple or pre-urodynamic tests, urodynamic investigations, and other investigations. I'll first talk about simple or pre-urodynamic tests and other investigation, and at the end I will be talking about the urodynamic investigations. So the pre-urodynamic test starts with the intake frequency volume chart, which is the most simplest urodynamic study. But it will give a lot of information about what the type of the incontinence is and whether this is truly a incontinence that the patient is complaining of. And another test, simple test would be the erect stress test or the modified pad test, where there is when the patient is wearing a pad, if there is a weight difference of 1 gram following coughing or following, say, 1 hour or given time, that is being taken as a significant test, and it confirms urinary incontinence. And there's a standardized International Continence Society 1 hour pad test with its limitation. And in this one, there is a standardized protocol, but the drawback in this test is that the patient does not need to empty the bladder prior to the test, so that we don't know about at which level we are going to start the test. It might be an empty bladder, or it might be a bladder filled with about 500 milliliters of urine. And in the standard test or the 1 hour ICS pad test, the investigator can prolong the test beyond 1 hour if the patient feels that she will develop incontinence after 1 hour time. Because of these limitations or drawbacks, there had been proposed a modified 1 hour ICS pad test, that in that the patient has to empty the bladder prior to the test, and whatever the reason, whatever the test result is, the test is terminated at 1 hour time. So the next pre-urodynamic or the simple urodynamics test would be the uroflowmetry. And with a simple uroflowmetry, we can, depending on the type of the curve and the shape of the curve, we can come to certain diagnosis, including bladder outflow obstruction and incontinence as well. And for uroflowmetry, make sure that the patient voids more than 150 milliliters. If not, we should always request for a repeat uroflowmetry. A uroflowmetry diagram less than 150 milliliters of voided volume is not considered a good test. And when the bladder is comfortably filled, at least 2 hours after the last void, we should start the uroflowmetry. And the normal curve is a bell shape, and the average flow rate would be 15 meters per second. And the next simple urodynamic is residual urine measurement, either by ultrasound scan or by post-voidal intermittent catheterization. And then we should always request for urine analysis to exclude any evidence of urinary pathogens, that is urinary tract infections and cystitis. So before going into the proper urodynamics, other ancillary investigations would be ultrasound scan, KUB, micturating cystourethrogram, and IVU. And almost always never forget to do a cystourethropy, either flexible or rigid cystoscopy. And the most important investigations are the urodynamics. Those are the physiological study of bladder and urethra function, and it aims to confirm the incontinence and determine its type. And it also aims to evaluate the detrusor function and to identify risk factors for upper tract deterioration. That is, whether there is a high pressure system in the bladder. And the principles when you are doing a urodynamic is that always make sure that the patient feels comfortable during the study, because sometimes psychological impacts would alter your urodynamic test results, because in certain situations when people are many people are looking at the patient might feel uncomfortable to initiate urination, and therefore the test results would not be ideal. And proper methodology and quality control is also very essential in urodynamics, because the most of the sensors are very sensitive, and so frequent quality control and calibrations are very much essential when you do urodynamic studies. And it should be always done by a trained person who is able to interpret the results. Therefore, you can give a test result at the bedside as well. And also, you should always stick into the standardized techniques and the terminology, so that the results can be interpreted and compared by any person worldwide. And as for the principle, any other investigation, we should always look at the patient, not at the test results. So interpretation of the result should be always in concordance with the patient's symptoms and presentation.
You have a 5
And
minutes.
urodynamics should be carefully selected. Urodynamics should be carefully selected, and it is indicated when there's a clinical, the clinical evaluation with the history and the basic investigations are equivocal, and when the usual treatments have been failed for the working diagnosis, and when considering for invasive treatment for correction of incontinence.
And you have a 5 minutes.
Okay. And there are simple and complex urodynamic studies. I would not be going into the detailed description of this investigation. And moving on to the last part, the management of incontinence. Always start with general measures by doing fluid restrictions, fluid constipation, if any, and teaching the patients pelvic floor exercises and estrogen replacement where necessary. And in certain cases, decide whether the patient needs a long-term catheter or clean intermittent catheterization. And I'll be discussing about the management in general stress on incontinence and urge incontinence. So to start with the general stress, genuine stress incontinence, the conservative management would be the first attempt, and it is indicated when the patient refuses surgery or if the patient is severely ill, either physically or mentally, and if the patient is having childbearing wishes. And the conservative measures would be starting with pelvic floor exercises, weighted vaginal cones, electrostimulation, and pharmacotherapy. But unfortunately, there's no definite pharmacotherapy for genuine stress incontinence so far. And apart from pelvic floor exercises, all the other measures have not been scientifically validated so far. Then I'll be moving to the destructive instability. The conservative management in destructive instability includes bladder training, where the patient is advised to postpone voiding as much as possible. And it has been reported that about 88% of the cases, within 3 months, there'll be success. But long-term success has reduced about 40% in 6 months' time. So it always depends on the patient's dedication for treatment. And pharmacotherapy is another form of conservative management in destructive instability. Commonly used ones are antimuscarinics, antidiuretics, and estrogen replacements. Out of these antimuscarinics, tolterodine has a great action on the bladder compared to the salivary glands. And the other measures like acupuncture, hypnotherapy, and TENS have not been proven to be beneficial. And as urologists, most important part is the surgical treatment in female incontinence. And this is the key concept that one should be bearing in mind. The first attempt of continence surgery produces the best result than the repeat procedure. So the main principle of surgical treatment for incontinence is to elevate the bladder neck, support the mid-urethra, to increase urethral resistance, and to correct prolapse if there is any. And the options available are bulking agents, needle suspension, and colpo suspension, and sling operations. And the last one would be artificial urinary sphincter. And just a few facts about bulking agents. The commonly used bulking agents in the past were like collagen and PTFE and silica particles, but now the recommended ones are the microcarbon particles. And needle suspension has been a surgery of the past. Now, because of the poor long-term outcome, it is no longer practiced. And the the gold standard so far is the Colpa suspension, namely the Birch Colpa suspension, with a long-term success rate for about 90%. However, this Birch Colpa suspension has its own high mobility rates, including voiding dysfunction and formation of rectocele and bleeding. But still, it is considered as the gold standard for genuine stress incontinence. And about
final minute.
Yeah,
Last
and
minute.
about whether laparoscopic is superior than the open Colpa suspension. The open Colpa suspension has been proven to be superior to a laparoscopic closure. And sling operations have also been developed so far, and the artificial urinary sphincters are more expensive, but still has a better outcome compared to the other methods. And for detrusor instability, there's no proper surgical management so far developed. So it's mainly a non-surgical management. And the last resort would be to do a gland cystoplasty. Thank you.
An excellent presentation, and so I just want to know what are the anticholinergics right, incontinence?
Sorry, sir, I couldn't get your question.
What are the anticholinergics available in Sri Lanka currently?
As I said, the commonly used ones are tolterodine, and then we have I don't know whether the terbuline is available in Sri Lanka, but commonly used one what we use is tolterodine, and it has a better affinity and efficacy towards the bladder.
Solifenacin also there.
Yeah, and oxybutynin is also there with poor, say, comparatively low outcomes, but cheaper for the patient, so commonly used.
Nalin, any long-term concern about giving anticholinergic in elderly people? Any concern? Other than the routine side effects like dry mouth and things, any long-term problem?
You can't think of.
Will it cause cause dementia?
Yeah, it can cause neurological. It has neurological effects, but the evidence so far had not given very strong evidence that it will cause neurological effects. But yes, there's a concern about neurological issues with antimuscarinics.
If anticholinergics are not working, if a patient have a severe overactive bladder, any other options? Any intravesical options?
Yeah, we generally use botulinum toxin, but I couldn't find any evidence or guidelines for them to be used in detrusor instability. So.
Yeah, it's widely used, Nalin. There's a definite management for there's a place for botulinum toxin. Do you know the mechanism of action of botulinum toxin? How it's act?
I think it paralyzes the detrusor temporarily.
Yeah. Read about it. It's acting a protein called SNAP protein. So they will ask this in question. So you have to know the mechanism of action of the botulinum toxin. Right. So botulinum toxin can be given in overactive bladder. Any other situation we give botulinum toxin in the bladder? So detrusor overactivity can be two types, isn't it? One is idiopathic detrusor overactivity. Other one is neurogenic detrusor overactivity, spinal injuries.
Yeah.
So then you have to know the difference in those and any different studies. There are two expert study, like one is EMBARK study and things. So better read around it, right? Botulinum toxin is a popular topic overactive bladder.
You know the mirabegron. Have you heard of the drug called mirabegron?
No, I have no idea.
Yeah, again, it's a popular topic, the mirabegron. You have to know the side effects and which receptor it's act. It's a beta-3 agonist, so and side effects like hypertension. So what is the absolute contraindication for giving anticholinergic like tolterodine or sulfenacin? Do you know any absolute contraindication?
Urologically, if there is a significant postcoital volume that can be worsened, so usually it's avoided. Apart from
any ophthalmology condition?
I think it's in first angle glaucoma. It should not be.
Very good. Yeah. So, while I was in overseas training, I have given this, and I have been scolded by the boss. So, close angle glaucoma is a contraindication, and myasthenia gravis.
Dr. Gobi and Dr. Suranga, can I add something upon here?
Yes. You can add.
All right. Nice presentation, Nalin. As Gobi and Dr. Suranga mentions, mirabegron and Botox are very big here in UK at the moment. Botox is given, as Gobi mentioned, in a very wide variety of female and functional urological conditions, apart from detressor hyperactivity. The other thing that I would like to add to this discussion is about the tapes. So in UK, tapes in females are banned now. So no female condition can be treated with the tapes now. All TOTs, TVTs are banned from 2018 July. So you cannot offer TOTs or TVTs for genuine stress incontinence or any other condition in UK. So that has gone out of favor, but Botox has come in and filled up the gaps everywhere in female urology. Thank you.
Expert, any other questions for Mandasena sir and Anuruddha sir?
Yes.
Ask any.
Yeah, now in Sri Lanka, can you hear me?
Yes, sir.
Yes, sir.
Now, just I want to give a little more information about the incontinence. Now, genuine stress incontinence in our setup. What are the available methods we have in this country? What are the things we do commonly? Surgical procedures.
Nalin.
What I have seen, sir, is one thing is TOT and TVT as well.
Now. It's banned now. Nobody does it now.
Yeah.
Because all these complications and things like that. So we have
I have seen birch pulp suspension as well.
Yeah. So, but my preference is autologous pubovaginal sling, which is very, very effective methods in this country to treat patients of genuine stress incontinence, right? So if you go to the literature, you will see the results are quite good. And it has been practiced in my unit for the last about 20 years now. So we have done a lot of cases and the results are very good. So that is a very good option. I think we should learn that, our trainees should learn that, how to do a proper autologous sling, because it's long-term results, complications and everything quite good. It gives a very good results, and long-term results are also very good. Yeah, we can compare with the birch, the results are same, but it has a wider application. For example, if you have a failed birch or any other procedure that is mainly the birch, the retropubic suspension, your next option is to go for a pubovaginal sling, because we don't do now TOTs and CVTs. So that is a very good option that I think the trainee should learn this, how to do this procedure.
I think
Yes.
Nande is correct. I think Nande is correct because internationally also it is becoming very popular. And I think at the sessions this year, next Friday, I think Roland Moll is going to give a lecture on that also. So I think if trainees can go and watch Nande doing it, it will be a great thing. It is coming up in a big way.
Yes, sir. Nandasena sir, before doing the sling, do we do urodynamic study before the surgery?
No. We don't uncomplicated stress incontinence doesn't need any investigation. It's a clinical diagnosis. Only thing is you should know. Now, if you look at the stress incontinence, there are two components for the stress incontinence. One is hypermobility. Second is intrinsic sphincter dysfunction. So the contribution from these two components varies in each patient. And unless there is a complicated genuine stress incontinence, that is a patient who had previous surgery, any vaginal procedures, any failed birth, or any neurological disorder, there may be a case for urodynamics, but otherwise, for a pure, uncomplicated, genuine stress incontinence, what I would do is a UFR culture, fasting blood sugar, and a scan just to see there's a post residual volume, just to see whether the detrusor is functioning well. Otherwise, I don't do any test, and it's a clinical diagnosis. And I don't do urodynamics unless also it doesn't give much information in a stress incontinence setup.
Thank you, sir.
So you are taking a rectus sheath as a sling.
Yeah, we take the rectus sheath.
So it has a dynamic component as well, Nanda, isn't it? That is a big advantage.
Sorry?
It has a dynamic component also when you compare with artificial things.
Now patients who have, this intrinsic sphincter deficiency is a very underdiagnosed thing, and also it's not very well defined. But it is there. That is the reason why the treatment for these retropubic suspensions fail, because we don't identify it preoperatively. There's no way to identify it properly. There are some tests, leak point pressures and urethral pressure, urethral profile pressure methods. We do it, but it is if the patients have is intrinsic deficiency component contributing to stress, the sling procedure is quite good. It's very effective. So that is why failed birth will respond to a pubovaginal sling.
Okay, sir. If a patient come to you with a medically resistant overactive bladder, you have given everything.
Yeah.
And how do you manage, sir?
I go for Botox.
Right. So do you give intradetrusor injection or submucosal injection?
We give it to the detrusor, so it's very difficult practically to see, but when you inject, you see a little bit of a bulge coming. So that is how you could see, but you give it to the detrusor.
So you give 100 units. So
yeah, we avoid give 2 vials and we avoid the trigon.
Right. Do we have mirror backbone in Sri Lanka, sir?
We haven't come across, I don't know.
Not yet, Balagobi.
Okay, sir. Right.
And if there's uncontrolled hydration, we have to move prescribing mirror. Is it good?
Yeah. So what brand of botulinum toxin we have? Is it allergen or is it the dry pose? Because the doses are different in.
I don't know exactly. It's
Yes.
whatever available in the MSD, we get it from the MSD. It's available in our Indo pharmacies. So.
Okay. Right. any other question to Nalin or to the experts?
So I have a question to the experts. Is there a place for bladder denervation in stress incontinence?
What do you think that is? I think it was practiced early days, but not now. But it's more stress that is for
No, not for stress, sir, but for
urge. Urge.
urge and yeah,
But I think it was
instability.
practiced. Yeah. It was done earlier, but I think now it's not practiced.
Duloxetine also.
Yeah, duloxetine is not the first line or second line, but yeah, if a patient is not fit for anything, then we can try it. Right. In the absence of question, Dr. Suranga, you can move to the next speaker.
Yes, next. So second topic is bladder pain syndrome, going by Dr. Tilina Samarasinghe. He has a 10 minutes to his presentation, and I will let you know at the 8 minutes. Over to you, Tilina.
Yeah, I think I can't share the screen yet. Dr. Nalin, all right, okay.
All right.
Right. Get back up. Right. Good evening, everyone. I'm Tilina Samarasinghe. So my topic for today is bladder pain syndrome or interstitial cystitis as it was known previously. So before I start, one second. So in the definitions, basically the American Urological Association and the European definitions both highlight the same things. It's basically an unpleasant sensation which may be pain, pressure or discomfort. And it is somewhat chronic. It should last for more than 6 weeks according to AUA, and the Europeans have a little bit of a higher threshold with a 6 months delay, 6 months of symptoms. And it has to be perceived in relation to the urinary bladder, and it should be accompanied by urinary symptoms such as persistent frequency. And AUA highlights that there should not be any infection or another cause. So these are basically important because there are overlapping symptoms, and there are so many other symptoms that diagnosis that we have to exclude. Epidemiology wise, it predominantly affects the females, 5 to 1, about more than 5 to 1. It is usually in females, and the prevalence is somewhat more commoner than we think. And there are so many associated symptoms which are important to exclude, as I mentioned previously also. Regarding the etiology, there are multiple etiological factors that have been highlighted. Basically, it is to do with either increased sensitivity, either due to neural or humoral neural mechanisms, or the effectors. So that is either the mast cells, which may be associated with increased activation, just like an allergic reaction, or the C5 activations and substance P release, or it may be a defect in the bladder epithelium, where the bladder epithelium glycosaminoglycan layer or the protective layers are abnormal, and there is increased sensitivity to whatever harmful toxic substances that may be in urine, causing a kind of local inflammatory reaction. So there are some other theories as well. But all in all, these patients present with, as I mentioned, frequency, urgency, and nocturia, mainly irritative symptoms. And there may be pain, suprapubic, and there may be pressure or discomfort related to bladder filling mainly. And they say it is typically relieved by bladder emptying. which in some of the patients might not be, but this is clear regarded as a classic symptom. They may have pelvic pain as well. So it's not only the classic irritative symptoms. And these symptoms are frequently considered as recurrent UTIs and cystitis episodes, or maybe culture negative UTIs. And so they have been on antibiotics for a long time and or recurrent treatments, but they have to be differentiated from recurrent UTI, which is a separate entity. So it's a very busy slide with a summary of assessment and evaluation. Basically, this highlights my whole presentation. First is diagnosis with history and examination, urine analysis and urine cultures to exclude other diseases. So many other things also which we can think of for these symptoms. And then these confusable conditions should be excluded. UTIs, overactive bladders, and constipation dominant IBS, so many others. So if those are identified or suspected, we have to treat it first and then see whether the symptoms improve and then proceed from there. If not, if those are not there, then again, whether there are any complicated bladder pain syndrome, incontinence, retention, microscopic gross hematuria. If those things are there, somewhat abbreviated pathway into early cystoscopy, urine cytology, imaging studies to exclude basically sinister pathologies. If not, we go into the benign empirical therapy algorithms. So this is actually a kind of diagnostic feature of interstitial cystitis, but it is only seen in 10% of the individuals. It is called a Hunner's lesion. As you can see, there is a arborizing vascular pattern, pink or red area with vessels radiating from it, and there may be a scar, and there may be fibrin deposit over the scar. And it is important to note that during hydrodistension, which I will discuss a little bit later also, these scars will rupture and there will be classic glomerulation type, waterfall type bleeding. So that is considered an important diagnostic feature in cystoscopy. This is clinically significant. This is since it is related to the symptoms of pain and also sensory urgency. And destruction of these lesions have, in some reports, shown that there is symptom relief with destruction, either with fulguration or resection. But it's not uniformly accepted what exact treatment to do and what is the exact prognosis of these lesions, even the therapeutic implications. This is the other cystoscopic finding, the glomerulations on hydrodistension. And this hydrodistension is actually both diagnostic and therapeutic, as they say this disruption of these fibrotic patches may cause symptom improvement. The hydrodistension, the way it is recommended is to do distend the bladder for about 1 to 2 minutes with the water pressure of about 80 centimeters. And to diagnose, initially it said more than 10 per quadrant in 3 out of the 4 quadrants, but now it is found that it is not as important as it was mentioned previously. But still, it helps to classify the disease, and also since there's a therapeutic benefit, I think a lot of practitioners still use this hydrodistension. Then going into the treatment algorithms, the AUA recommends this tiered pathway. So these are again few overlapping tiers, but starting from very basic general relaxation, stress management, patient education, Going into more intravesical therapies, oral therapies, first line and second line, and then cystoscopy, some recommended in the third tier. But maybe in our setting, we may go for an early cystoscopy sometimes, but this is actually the AUA recommendation. So cystoscopy with hydrodistension, treatment of Hanna's lesions if they are there, and then fourth years going into introduced botulinum, and then neuromodulation, pain management, cyclosporin, and finally going into urinary diversion and surgical options. So this is again a little bit of a summarized summary of the TN system.
You have another 3 minutes.
Yeah. So this is another, again, symptom and management according to the symptom phenotype. So in the EAU guidelines, they have stressed this symptom phenotypes according to the U-point classification: urinary symptoms, psychosocial symptoms, organ-specific symptoms, infectious, neurogenic, and tenderness. And they have somewhat recommended this. I will go into the guidelines in the next couple of slides. And the differential treatment according to the U-point system is also recommended in the EAU. So quickly moving on to the last couple of slides, the guidelines. Basically, these are very short guidance on BPS, but they say no single etiology, does not correlate with cystoscopy and histological findings, and some subtypes may not be classified according to cystoscopy and histology. And regarding the management wise, rigid cystoscopy is recommended, but maybe not the first line. And associated, so it's just self-explanatory. I won't read all of it. But going into the recommendations, phenotype-oriented therapy is a strong recommendation. And then going into oral behavioral, physical, psychological techniques, dietary advice, amitriptyline, pentosan polysulfate, which I'm not sure whether it's available here. And then intravesical therapies, all of these: hyaluronic acid, protein sulfate, lignocaine with bicarbonate, heparin, either alone or in combinations. Weak recommendation. Trigonal injection of botulinum toxin A, strong recommendation when the intravesical therapies have failed. And yeah, so resection and coagulation of Hanna's lesions. So in summary, is a chronic debilitating disorder characterized by irritative symptoms. Exclusion of other organic pathology is very important in establishing the diagnosis and also in treatment. And clinical, urodynamical, and cystoscopic findings in the diagnosis. And management according to a TN system, starting from very conservative measures and gradually incrementing, finally even up to surgical measures. U-point phenotypic subtyping is also helpful in treatment. And establishing patient expectation and counseling about the disease is also very vital, since this is associated with a lot of psychological and psychological distress, as well as some psychological component to the symptom severity and quality of life. So these were my main references, basically AUA guidelines, EAU, and the Campbell Brainwash Urology. Thank you.
Question, Gobi?
Yeah, Trin, excellent presentation. Trin, have you seen any patient with bladder pain syndrome in Sri Lanka?
Yes. I think I have seen a lot of patients, lot of females with this kind of symptoms, and maybe I might have initially thought it's recurrent UTIs, but now retrospectively thinking, I think because we have been treating with multiple other modalities, but they still keep on having these symptoms. So I think there are few patients which I'm not 100% sure, but I think these patients are going into that category.
Right, good. And again, this topic is a popular topic in abroad. Why you think it's popular there but not popular here? Because this condition is more common in Caucasians, isn't it? Yeah. And Nandasena sir, so if you get this kind of patients, how do you treat?
It's a very difficult situation. I have 1 or 2 patients not responding to any of these treatment modalities. So basically, I refer to the anesthetist to manage the pain, and it's a very difficult situation.
Understand. Do you give amitriptyline, sir?
Yeah, all give amitriptyline, everything, multi drugs for pain relief, doesn't respond. It's a very difficult situation. I don't know what to do.
Yeah. Have you ever tried cystodistension,
It
hyperdistension?
doesn't work. It doesn't work. It doesn't work.
Do we have PPD, the pentosan polysulfate in Sri Lanka, sir? The Elmiron, do we have in Sri Lanka?
Not to my
That's
knowledge. I don't know.
popular in India. Do we have in Sri Lanka? Anuruddha, sir?
No, I don't think, Govind.
Okay. So the summary is a very difficult condition and very difficult patient. When they come in, we know that this patient in the distress have all the stress disorders. I think all will agree it's a very difficult condition to treat.
Yeah.
They give intravesical glycosaminoglycans like cystistat and hyocyst. They are popular in other countries, but it's not available here. Right. Do we have any?
Cystistat is available, isn't it?
No.
Yeah.
Yeah.
I think severe cases are very rare in Sri Lanka. I think there may be mild cases, but fortunately severe cases are rare, as Nanda says. So he has seen only 2 cases. So fortunately it's not that common. And I think what happens is if you try to make it a big illness and give a diagnosis and all, it becomes worse because there is a psychological component. This is my personal thing.
Yes, sir.
Therefore, in a way, this type of underdiagnosis in our setup is a blessing, actually.
Yes.
Excuse me, I'm Srinath Ileperuma. I just want to ask Dr. Bala, couldn't it be that the Caucasians have more because they are, over-reporting it, as Anuruddha sir very correctly mentioned. I think this is a huge problem in UK where there are a lot of patients who are refusing to even go home from the hospital, and they're labeled with this diagnosis, and basically they do not respond to any of these treatments, and this hydrodistension is done mainly just to comfort the patient and say that we have done something.
Yeah, I totally agree. It's like a irritable bowel syndrome. They have to control their stress and relaxations more than giving drugs, I think. It's a difficult condition. We all understand.
Yeah.
Right.
Hydrodistension, if at all, will have a very transient effect.
Yes, sir.
Probably it's psychological, as Srinath says.
Yeah.
It may improve for 1 or 2 months. That's all.
Yeah. Do we have any question to Dr. Thilina or experts regarding bladder pain syndrome? Dr. Surang, I think we can move to the next topic.
We can next one. No?
Okay, then we'll.
Okay, Tahayas, yeah.
From an uncommon cumbersome condition, we'll move to another common treatable condition. Most of them are referred from gynecologists, the partners or urologist partners in the pelvis. The topic is vesicovaginal fistula. Let's see what Dr. Gihana Halawat has to teach us. He has 10 minutes.
Yeah.
Gihan,
Yeah. Yeah, are you there? We'll move to next topic and then
Yes, we'll move to the
Dr.
next topic.
Yeah, Dr. Achudan, are you there?
Yeah, I'm there.
Achudan is there, yes.
Okay, and we'll move to the next topic is going to be pelvic organ prolapse. Again, an uncommon condition managed by urologists in this country. Over to you, Achudan. You have 10 minutes to teach us.
Thank you. I'll be talking on pelvic organ prolapse. So this condition, based on an anatomical classification, can go up to 50% in the elderly females. If you go strictly by the symptoms, it will be just about 3 to 6%. If you take the lifetime risk for surgery in this condition, worldwide, there's a 1/8 chance of a surgery for pelvic organ prolapse. Commonest risk factors, this is as common for like stress incontinence. So parity, vaginal delivery, aging, obesity, all are risk factors. The main contributing factor is thought that it's due
Achudan have a connection issue? Or?
Gobi, till he comes back, shall I speak
sir.
few words?
Yes,
No, he's
sir.
coming. Okay, sorry. Okay.
Achudan?
We can't hear you.
It's mute.
Is it Achudan is muted his mic or what?
fine.
It's a connection problem.
I can't share my presentation. It's not showing.
We can see your slide. Here.
Okay, I can't see my slides anyway. Okay, then so
We can see Achu.
okay, sir. Thank you. So an intact levator ani. So what it does is it releases the tension on the endopelvic fascia and the supporting ligaments. So this maintains a pressure gradient between the intra-abdominal pressure and the intravaginal pressure. There is a gradient maintained. So when this support goes due to trauma, there is a higher chance of pelvic organ prolapse. In females, usually pelvic organ prolapse is associated with lower unitary symptoms. Anyway, the prevalence is much higher in a patient with pelvic organ prolapse. So the classification is pelvic organ prolapse quantification staging. We divide the anatomy into 3 compartments: the anterior, apical, and the posterior compartments. And based on the severity of the prolapse, we give it 4 stages. So stage 1 is when the prolapse is 1 centimeter above the hymen, and stage 2 is 1 centimeter above and below the hymen. within 1 centimeter above and below the hymen, and stage 3 is beyond 1 centimeter below the hymen, and stage 4 is complete prolapse of the vaginal vault or the uterus. So diagnostic evaluation, this pelvic organ prolapse is a clinical diagnosis which we can direct with the per vaginal examination. Usually a lower stage prolapse produces very mild symptoms. So if our clinical examination and classification does not suit our symptoms, that needs a revisiting, we should examine the patient in a standing position, or we should evaluate later. Usually, we don't need to do any further test for this condition unless patient is only having stress urinary incontinence. Urodynamic studies are not routinely advised. The tests we use before we do urodynamic test in a patient with a combination of pelvic organ prolapse and stress urinary incontinence, we have to reduce the prolapse. So research has been done in different methods of reduction, such as manual reduction through swab, forceps. So multiple researches have been done. It has been demonstrated that there is 30% of occult stress incontinence cases in the population. So this is a very important factor, because post pelvic organ prolapse surgery, these patients are at risk of presenting with the stress urinary incontinence. So it was occult before the reduction. If you, this I have talked about. So following surgery of pelvic organ prolapse, there is a chance of the patient developing detrusor overactivity or detrusor underactivity presenting as a retention. So in this situation, urodynamics might help us. So there are certain parameters where we consider there is a risk of detrusor overactivity and chances for retention post-surgery, but there are certain conditions where detrusor instability, underactivity has been treated by pelvic organ prolapse surgery. And like I before told, NICE guidelines only advises urodynamics for the combination of pelvic organ prolapse with stress urinary incontinence only. If you take the disease management, pelvic floor muscle training usually advised as a first line of treatment for 3 months is one option. Then vaginal pessary use and surgery. And we can try a combination of these treatment modalities. Different researches have produced us the possible treatment modalities and the benefit for the patient. If we consider only lifestyle advice in pelvic floor muscle training, there is a clear-cut benefit for pelvic floor muscle training after 3 or 6 months of continuous training. So what is important is the compliance of the patient. If you consider pessary use with or without pessary use, the pelvic floor muscle training, there is a significant improvement from the only pelvic floor muscle training group, and pelvic floor muscle training versus pessary only, there is no significant difference. And if you consider surgery with surgery, surgery versus surgery with pelvic floor muscle training, there is no much significant difference. Pelvic organ prolapse surgery has also seen benefit, shown benefit for overactive bladder as well. We consider for pelvic organ prolapse with stress urinary incontinence. So the prolapse surgery could be done in a vaginal approach or through an abdominal approach. Postoperatively, most of the conditions, mid-urethral sling has been shown to give better results compared to pulpal suspension. And doing a combined surgery at the first instance and 3 months does not produce a difference between the two in a mid-urethric sling also. In abdominal pelvic organ surgery, the stress incontinence surgery did not was not inferior to combining it with a incontinence surgery. Can everybody hear me? Can everybody hear me?
Yeah, yes.
Yeah, okay, thanks. And if if you consider birch corpus suspension versus mid urethral sling, it favors in a patient who's undergoing abdominal sacral colpopexy. Results are favoring mid urethral slings. For vaginal pelvic prolapse surgery and occult stress urinary incontinence, also mid urethral slings are preferred. And for patients who are continent also, mid urethral slings have been shown benefit in vaginal pelvic organ prolapse surgeries. In abdominal pelvic organ prolapse surgeries for continent patients, birch corpus suspension is more preferred. These are just diagrammatic representations of the mid urethral sling and the birch corpus suspension. So before these procedures, there are significant adverse events such as bladder perforation, urethral injuries. And if you consider previously done TOT or TVT, there are some patients complain of significant pain as well. So this has to be completely discussed with the patient before the procedure. Thank you. And like Dr. Supan mentioned, TOT and TVT are banned in UK now, and they are now going more for autologous slings, such as from fascia lata and from rectus sheath. Thank you.
Thank you, Achyutan. Nandasena sir, if we get a cystocele, do we have to really do anterior repair? Or what is the indication when we have to do anterior repair in a cystocele?
So, I mean, it's without stress, a pure cystocele you can handle with the Kelly's repair. But if there is combined stress incontinence and a cystocele, Kelly's repair doesn't, it's not enough. So you have to combine with the pubovaginal sling. This is what I do. If a patient has a stress incontinence plus a cystocele, I do a repair, anterior wall repair with a Kelly sort of procedure, and then I put a sling over that. But for a cystocele, yeah, Kelly's repair is enough.
And pelvic organ prolapse, hysterectomy, is it our territory or is a gynecologist territory?
Nobody does it in our setup. No, people are not doing pelvic floor repairs, and this area is a bit neglected from urologist. So it's a good idea for somebody to develop expertise in pelvic floor repairs and all this prolapse. So there are a lot of patients coming, and we don't attend to this problem very much.
So we need a urogynecologist in future.
I think it's a good idea if somebody can develop this area, focus more on this.
Yeah,
problem.
and one more question, sir. Sometimes we get acute kidney injury with bilateral hydronephrosis and hydroureter with procedentia. In that kind of situation, just reduction and putting pessary is enough, or do we have to do a bilateral JJ stenting temporarily?
Better to keep, you have to do surgery definitely, because this will affect kidneys.
I'm talking about patients who are not fit for major interventions. Most of the time they are, obese and
they put circulages and then it settles.
I think no harm putting a stent if you really have this, because even if you reduce, there's no guarantee that you can say that the upper tract obstruction is relieved. So no harm putting stents.
We have to put a catheter as well, no, because of the urethra also.
Yeah.
So if that is a referral from surgical wards, would you stent and ask for gynae opinion, or gynae opinion first and stent, sir?
Combined,
yeah, always.
What I would do is, first, in such a situation, I would put a catheter and put a pessary and see what happens. If the creatinine is not coming down only, then I will go ahead with a stent. But otherwise, sometimes it may settle. I don't have a large number, but few cases that we have encountered, you can get away with a pessary. It is on a temporary basis until this is corrected, once the creatinine improves, etc. And a catheter as a initial thing.
Okay, sir.
I'm
Thank you.
not sure, but it's not an evidence-based thing.
Yeah. Any more question to Achyutan? Achyutan, if you get a patient with the valval prolapse, how do you differentiate whether it's an anterior or posterior prolapse or it's a central prolapse? But by the appearance of the prolapse?
Yeah, by the appearance of the prolapse, yeah.
But what is the difference? That's what I'm asking. What is how you differentiate anterior and posterior prolapse and the central prolapse? You will have a vaginal rugae in anterior and posterior prolapse, but central prolapse like UV prolapse, it will be very smooth and shiny. There won't be any rugae, isn't it? Yeah. Thank you. Thank you, Achyutan. And Dr. Suranga, you can ask Gihan to. Is it Gihan is back?
Yeah. Still not there, I think.
Gihan is here. Gihan is here.
Yes. Gihan is here.
Hello, can you hear me?
Yes, yeah, we can hear. Yes. I think Gihan can start on your his presentation on vesicovaginal fistula. You have 10 minutes.
Can you see my slides?
Yes, yes.
Yes.
So I will discuss about iatrogenic vesicovaginal fistula. The causes of vesicovaginal fistula are many. However, most commonly we meet it with abdominal hysterectomy, vaginal hysterectomy, like pelvic organ surgeries, and also with our genitourinary practice, whether bladder biopsy or in gynecology practice, vaginal biopsy can cause these vesicovaginal fistulas. This obstetric fistula is a different component where there is obstructed labor causing a fistula due to local pressure as well as soft tissue damage. However, there will be very large fistulas even with associated other injuries like rectovaginal fistulas. So better to avoid them rather than trying to treat them. And then there are always background of this radiation therapy and pelvic malignancy, concern of pelvic malignancy, inflammatory infection conditions, and foreign bodies which we have to address during the fistula repair. However, these are also causes for recurrent and difficult to treat fistulas. So that need to be kept back in mind. And then commonest cause for is the abdominal hysterectomy, which is 3 times more common than vaginal hysterectomy and other pelvic organ operations. What happens during this hysterectomy can be due to direct bladder injury or necrosis from the cautery, suture placed through the bladder, or if there is uncontrolled bleeding, blind application of sutures will cause this kind of a fistula. And also we have to keep back in mind when we are doing a previous uterine surgery, endometriosis, infections, diabetic patients, pelvic inflammatory disease, obesity, and prior radiotherapy patients who are undergoing pelvic surgery, that they have a high risk of developing a fistula. And these patients will present with the urine discharge from vagina, and which is an unexpected complication and very poor quality of life due to this. So that will affect our timing of surgery as well. And pain is an uncommon symptom. However, pain can be associated with cystitis or pelvic sepsis. After removal of the catheter, they will develop this leakage of urine. As I mentioned earlier, it can be associated with sepsis, ileus, hematuria, or irritability of bladder. And presentation can be delayed in radiotherapy patients even for months and years. So differential diagnosis for this vesicovaginal fistula can be urinary incontinence, which we discussed earlier, and urge stress incontinence, and uterovaginal fistulas. important to differentiate with subsequent investigations. So initial examination, we would do a speculum examination, looking at the anterior vaginal wall, whether there is any visible palpable defect, and then size, location, number, and surrounding inflammation should be documented and noted, because that will determine our approach to the surgery. And then whether there is associated pelvic organ prolapse, atrophy, and introital size, if we are planning for a vaginal approach. And then this 3-SOP test or blue dye in bladder test to identify occult cases is done to confirm that there is leakage, and also we routinely do a cystoscopy to identify any visible defect in the bladder. We look at both ureteral orifices and identify the relation to this fistula with the nearness of the ureteral orifices, and any suspicious lesions, which aspect can be a malignancy. And there are also described this indigo carmine test, which is an intravenous agent used to excreted by kidney to identify any ureteric injury in blue dye. And then this double dye test, just to confirm whether there is associated ureteric injury as well. Methylene blue combined with oral phenobarbital, which is a yellow kind of a dye excreted by kidney again. And combine these two, we might detect, but sensitivity, I'm not sure. So what in our setup we will do is voiding cystoureterogram or probably a CT IVU, contrast IVU, with the IVU phase to detect these complex lesions. And then, and also it is also important to look at the upper tracts. Even though we find a vesicovaginal fistula, there can be associated ureterovaginal fistulas. So that is very important. And then urine culture, creatinine, and evidence for infection has to be looked for. So this is the vaginal view of anterior vaginal wall fistula in the first diagram, and the cystoscopic view in the second diagram, where the vaginal mucosa is seen through the bladder-based lesion, bladder-based defect. And in early cases, there can be this edematous appearance, not clearly visualizing a lesion. However, we have to suspect it. And then the third diagram showing a voiding cystoureterogram. Clearly, there is a contrast excitation into vagina. And then there is this classification of Go and Walgic classification. They use the position from the external ureteral meatus and the size of the lesion to classify their these vesicovaginal fistulas. However, the Go classification is mentioned that it is superior, predicting whether we can close it or not. When the number increases, type 1, it's more closer to the ureteral meatus, like that. And probably in the comparison studies and in the research setup, we can use this classification. However, whether there is any practical use, we have to think about it. And then moving on to basic management of this vesicovaginal fistulas after initial examination and investigations, we have to decide whether it's a recent vesicovaginal fistula or established fistula. And there is place for conservative management, and whether it's a primary fistula, possible vaginal repair, recurrent fistula, possible abdominal surgery, and post-irradiation, which is a very difficult condition to treat because of recurrences and poor tissue healing. Whether we are going for delayed repair. I will discuss more detail in selection of these surgical or treatment procedures. So basically conservative management, surgical repair can be done vaginal, abdominal, and in foreign countries, robotic repair. And our goal of treatment is the rapid cessation of leakage and complete urinary and sexual function. So we have to have a balance between timing of our surgery, because doing it early will be benefit for the patient from quality of life. However, it might adversely affect if there is edema and inflammation, which is persistent. And then conservative management can be done with indwelling catheter with anticholinergic medications, and we have to evaluate them weekly until 2 to 6 weeks until it heals. And there is a 28% healing rate if it is a primary repair, uncomplicated one, which will have a good effect. And also the size of the fistula matters if it is a small one. And ongoing continuous leakage after catheterization despite functioning catheter is a indication for surgery. And electrocoagulation is done with this small 3 millimeter, less than 3 millimeter fistulas. We are trying to ablate the epithelial tract and then allow it to heal its secondary intention, probably for very small fistulas. And then with the radiotherapy history, the conservative management is usually not recommended. So moving on to surgical repair, first surgery is best. So it has to be done carefully planned and done properly. So timing, no consensus, usually individual basis. However, early uncomplicated vesicovaginal fistula tendency is to go early repair because of patient complications to the patient. And then complicated abdominal surgery history, we might allow the inflammation to settle and also the additions to settle because our approach would be difficult. And we might allow 2 to 3 months of recovery from the initial surgery. This is the basic comparison of those two techniques, abdominal or transvaginal techniques. So basically the transvaginal technique is indicated for uncomplicated low-lying fistulas. Abdominal approach would be easy for high-lying fistulas and for complicated ones. So
2 minutes. Yeah.
Yes. Hello.
Yeah, you have another 2 minutes.
Okay. So in abdominal fistula repair, there will be higher complication rate, probably related to we are dealing with more complicated fistulas in that manner. So another disadvantage of this abdominal surgery would be we will have to relocate the ureters if it is closely lined to the ureter, because our incision is big and we are opening into the bladder. And there is excision versus no excision controversy there. But however, if there is a fistula is not, edges are healthy and healthy edges are there, there is no need to excise every case. And adjuvant flaps are necessary, especially when we are dealing with recurrent fistula. And always we try to have a flap in between and separating suture lines. And post-operatively, antibiotics and transutural catheter continuous drainage without blockage and perioperative counseling of recurrence is necessary. So this is a vaginal flap splitting technique for low-lying vaginal fistula, opening up the vagina with the inverted U-shaped incision and then developing tissue planes in bladder and the vaginal wall, and closing the fistula separately and without overlapping suture lines, repairing the vaginal defect. And cystoscopy is done prior to the procedure to insert the guide wire. And similarly, in the vaginal abdominal approach, opening up the vaginal and exposing the fistula, excising of the fistula tract and vaginal cuff, and then suture line, and then omentum interposed between the fistula and the bladder wall. So adjuvant procedures, Maritus flap is this labial flap, fat flap used for vaginal repair, and in the abdominal approach, peritoneal flap for gate omentum commonly used. And in very rare case like radiotherapy, very difficult to treat one, you might consider urinary diversion, even upper tract diversion. And then we have to follow them up because there is high rate of sphincteric incontinence. If we identify, we have to treat it. So that would be my complete presentation. Thank you.
Thank you, Gihan.
Thank you, yeah.
I think Manjula sir is there. Manjula sir?
Yes, yes.
Sir, if you get a referral from a VOG after a TH and day 4, they are saying there is a vaginal discharge, fluid discharge. What do you do, sir? You will go for a surgery immediately, or you put a catheter and wait, or if you are doing a surgery, when you will do it?
Now, Balagovi, I find that usually it doesn't happen in the first 4 days. You know,
Yes, sir.
usually
Yeah.
the gynecologist has or the obstetrician has already discharged the patient. About
Yes.
2 weeks later, only the mother or the woman will come and complain that she is leaking urine from below. So I have now noticed then and again, there is a bit of a delay. Unless, of course, you detect the bladder injury at the time of the operation, they'll call you.
Yeah.
But this leaking complaint happens about few weeks later.
Yes, sir.
Because it's a very bad symptom for the patient, especially when there's a small baby also in hand. I would, of course, as the old concept, the old teaching, wait for the 3 months for the repair. But initially, just to buy time, I would arrange the cystoscopy, IVU, or a CT, IVU, and try to figure out where is the lesion, but we'll not try to explore and close it sooner than 3 months.
Okay, sir. Anuruddha sir, what is your view?
Yeah, a few years ago, I had a big argument on this with Julian Shah from UK. He also agrees with Manjula. He says you have to wait for 3 months. My argument is this 3 months delay may be appropriate for obstetric fistulae, where you get necrosis and ischemia of a large area of the bladder, and the defect is big, and we don't know the exact demarcation of the necrosis and healthy tissues. And those days, good suture materials are not there. When you repair with catgut, you know, you are bound to get problems. But now that we don't see obstetric fistula, I mean, for several years, I haven't seen an obstetric fistula. We see only gynecological fistulae. And those are small defects. You know, it is just they have put a stitch, catching the bladder or clamped it. Now we have good suture materials. Polygalactin sutures are very good. A lot of good characteristics are there. Therefore, I of course don't wait for 3 months. It's a very disabling symptom and a complaint for a woman to have urine leaking from the vagina all the time. Even a husband and children hate her. They don't want her in their house even. Because of the smell and all these things. Therefore, I am a bit more sympathetic and I try a little early, and it hasn't been a big problem because of those reasons actually. But if you have an obstetric fistula, large defect, and if you don't have good suture materials and all, then of course, better to wait for 3 months. And to answer your question, if you have a little leak on the 4th day, I would, of course, will keep a catheter and give a little bit of a chance for healing. Few cases it has worked. It's a minority, I would say, less than 25%, but still I think it's a little worth trying it. As Manjula says, then there's a time you can buy a little bit of time and you don't have to rush immediately. And so that you are in a sort of intermediate stage rather than waiting for 3 months, but you're not rushing immediately also.
Okay, sir. Thank you. Nandasena sir,
Yeah.
do you prefer abdominal approach or vaginal approach?
So far, I have done all cases, my cases by abdominal approach because I need to get the momentum in between. So I have no experience doing labial flaps, but momentum is very good and results are very good. So I go for a abdominal approach.
Okay, sir. Thank you. Manjula, sir,
Yes, tell.
this may be not related to this one. If gynecology team is calling us, they have suspected damage the ureter via the financial incision. Do we have to do a cystoscopy and retrograde study and then decide the further management, or else we have to go and see the open site and repair and put a stent there?
Yeah. Now, Balagobi, the situation is now, it depends on the location. Now, usually this obstetric surgery has occurred in an obstetric hospital or a general theater, where you won't have your armamentarium to deal with all this C-arm, X-ray lucent table, cystoscope, and this retrograde facility. So,
Yes, sir.
when we are called to attend to a DMH or Castle Street Hospital case like this, it's we are limited in choice. So you go there and try to fish out the ureter from above in the normal obstetric field and try to see whether there is a damage. Because the ideal situation would have been to do a cystoscopy, flash some contrast and see whether the line is in continuity. So because it's difficult to arrange logistically only, we will try to dissect the ureter and try to figure it out. And any case, if you are passing a stent, we do a ureterotomy and pass the stent up and down. Sometimes there is no injury at all, or it's a bit of a kink which we have to release. But most of the time, it ends up in a quick reimplantation of the ureter to the bladder at the end of the operation.
Thank you, sir.
Sometimes some patients after VVF repair, they complain again a small leak. We don't know whether it is a periureteric, pericatheter leak or a failure of surgery. How will you deal with those kind of patients?
So where would the leak take place? Pericatheter?
We are not sure whether it is pericatheter or vaginal leaks.
If you think it's a pericatheter leak, Taha, what you can do is give some oxybutynin or solifenacin and see. That might reduce the pericatheter leak. But generally, it should not leak from the vagina if you have done a good repair.
In such case, will you keep the catheter for a shorter period or longer period?
Not a shorter period. I would give some antimuscarinics.
Yes,
and
sir.
keep the catheter whatever the duration that I would like to have after a VVF.
Yes. Anuruddha sir, one more question.
Yeah.
Placenta percreta, the gynecologist obstetrician sometimes call, and when we go enter in, there will be a warfarin like feeling. They are giving blood, and sometimes we can't see where is the bladder even. So, do you have any hints or feedbacks how to deal with that kind of disaster situation, sir?
Yes. What I generally do is we tell them do whatever they want. Don't worry about the bladder. You just do whatever you want. Stop the bleeding and save the baby, and then you give it to us. So I will stay inside the bladder, and then once the bleeding is controlled, they have got rid of the uterus most of the time, and then I will go there. And most of the time, yes, it's a ragged tear that you get. It's very difficult, but only thing is because the vascularity is good, if you just approximate and suture, I think it has sealed. It has never been a problem for us in this thing, in leaks. It's a very poor repair that you can do. I agree, but it always heals with the catheter, and it's never a problem. I never do these methylene blue tests and checking this thing. Whether it is a good anastomosis, because I never do a good anastomosis. I just approximate and ensure that vascularity is maintained, and keep a catheter for a little long time, maybe 3-4 weeks, and they invariably heal. We have done quite a number actually, because Colombo South is a place where they do a lot of placenta accreta as a referral center. Therefore, we get a lot of problems. But we have got away. I think you don't have to have this perfect anastomosis. I think it's a It's a misnomer. And it's a thing that have been taught from generation to generation, this watertight anastomosis of the ureter, the bladder, taking the bladder sutures with methylene blue instillation and all these things are not necessary because when you do a suprapubic cystostomy, when you pull out the catheter, it heals. You don't check with methylene blue. So it's the same thing. All you need is good drainage of the bladder and the bladder will heal, provided that you haven't caused ischemia. That is the thing that is really important. But in placenta percreta and all, there is no problem with vascularity. It's very good vascularity. They heal very well. Nothing to worry. You just approximate. Only thing is don't catch the ureter. So you have to be careful. That is the only thing that you have to be careful about.
Thank you, sir. Dr.
I
Suranga,
have
I
a
think.
small addition to that, Balagobi.
Yeah, yes, sir.
Now, when I go across to DMH to close, after this battlefield type of bladder injury, I find now there is some more than one defect in the bladder. So even the obstetric registrar or the SROs doing the operation have located the defect. It's a huge defect. But when you try to, be very confident and put a huge catheter balloon, like a 30 ml balloon to get the bladder location and try to close whatever the ragged edges that are there so that you won't see the catheter balloon. After you have done your approximation in one defect line, suddenly there is another hole in a totally different area. Yes. Then you try to close that, you realize a small bridge of tissue which is between the two defects are undergoing necrosis. So you have to cut that piece off. Like that, you have a few buttonhole areas in the bladder, usually more than one defect. So it's like a football. Finally, like patches of a football, you have sutured in so different lines. But finally, as Anuruddha sir said, they won't call you to reoperate. They will anyway heal around the catheter. But finally, the patient ends up with a very small bladder.
Yeah, good.
So have you encountered any ureterovaginal fistula in obstetric setting or gynecology?
I think the TOT, TVT era, there were some, but not now, isn't it?
I haven't encountered, Suranga. Yeah, very low, almost very close to the bladder neck. We have done transvaginal repairs, but urethro, no. It shouldn't cause any symptoms, is it? Or
urethrovaginal? There is no incontinence actually because his sphincter is working.
Yeah. Patient may not even come, I suppose. It is a mild one. Suranga, I don't know, unless.
Dr. Suranga, shall we move to
the... In case of a ureterovaginal fistula, I have two questions. Is there a possibility for a trial of stent? If you detect it early with a retrograde, is it worthwhile putting a stent and wait for some time, and how long we can wait? That is one question. And second question, when we repair, if it is very low ureteric one, is it just a reimplantation of ureter is enough, or do we have to really explore the fistula and close the defect?
Is Satisan?
Anomilan.
Who asked the question?
Dr. Anomilan.
Sorry. Right. Anomilan. Yes. What for your first question? Yes, you can try a ureteric stent and see. If you are lucky, it might work. I had done large number of ureteric injuries, but most of the time stents didn't work. Ultimately, I had to reimplant. Therefore, I am very reluctant now to put stents and try. I will just straight away go ahead and do a reimplantation in the first go. But theoretically, what you say should be okay. But even if it heals, Anomilan, what happens is they end up with a ureteric stricture and you will have to do the repair subsequently. So there is a little bit of a disadvantage. Second question, I can't remember now.
No, so if it is a very low ureteric ureterovaginal fistula involving very lower ureter, do we have to really explore the fistula and repair?
No.
Or, just reimplantation is
enough. I would just do a reimplantation because what happens, Anomilan, is trying to locate the lower pit is bit a tricky thing because no gynecologist will like to damage the ureter. You know, if they have damaged means there had been some bleeding, some difficult clamping, and they have done some jugglery to control pelvic bleeding. So if you try to locate the lower end, you know, you're asking for trouble and you're going to go into those pelvic veins and vessels and asking for trouble. Therefore, I will just do a reimplantation.
Okay, thank you, sir.
I think the vesicular junction is enough to control the retrograde movement of the urine.
Yes, yes, true. I agree.
Right, thank you.
Then there is a small warning also in this ureterovaginal fistula. Now, patient gets a false sense of security, thinking that the situation has improved when the ureterovaginal fistula dries up. Recently in July, just July or June this year, a patient came with, this sub story of leaking a lot of urine from the vagina, and our general hospital director is also interested about the patient, and they were pressing me to explore and do something immediately. I said, refer to Dr. Susanta if you want emergency operation. I, of course, waiting for this 3 months thing. But when I did the cystoscope just to buy time, to satisfy the patient that something has been done, there's nothing wrong in the bladder. Then I realized at the time of the operation, I have asked the anesthetist to give furosemide just to see where this urine is coming from. It's pouring from the vaginal vault. So the repaired vaginal suture line, a very clear urine. And when I put the cystoscope into the bladder urine is turbid and smelly and all these floating particles are there. But the urine coming from the vagina is just like tap water. So then I realized it's one of the ureters thing. Then to see in the ultrasound scan, left kidney was swollen. So some mild hydronephrosis building up, but there is no pre-op ultrasound scan. So you won't know whether this has been there or before. So I have written for IVU, trying to locate this ureteric fistula. About August 21st, patient had got a date for the IVU. And after that, patient did not come with the IVU report. Now, recently in October, just 2 weeks back, patient comes for some other, like a urine infection. So I asked, what happened to your IVU? The patient said, my leak dried up. To realize that the ureteric fistula has dried up and the kidney is thinning away. So now I have asked the patient to have a PCN, trying to see whether that kidney is any more functional, a young person. So to try to salvage it. So the lesson there would have been, if you suspect a ureteric vaginal fistula, even if the leak settles, you have to manage the kidney, because finally that person is going to lose the kidney unit.
Yeah, I also have a small message to the trainees. If you have a ureterovaginal fistula, if you suspect, do an urgent CT urogram and please reimplant the ureter within 24 hours. That should be the management. I don't think you can wait ureterovaginal fistulae. You don't need any additional tests. I think if you want to save that kidney, that should be the way. So that's why even for vesicovaginal fistula, that I said it's early repair is the best. Early repair is the best for even ureterovaginal fistulae, because then otherwise sepsis, fibrosis, very difficult. Patients are not agreeable because, as Manjula sir said, it may dry up. So don't wait, don't delay. Ureterovaginal fistula should be repaired immediately. That's what my personal thing is.
Yes, thank you, sir. I think we can move to the Milan.
Last one.
Yeah, then we can discuss all the other questions at the end of the session. Yeah.
Final presentation is by Dr. Milan. He will talk about the urinary retention in women and urethral diverticulum. Over to you, Milan.
Okay, sir. Good evening. Thank you very much. So I will be starting with female urinary retention. So as we all know, it can be classified into acute urinary retention and the chronic urinary retention. So female acute urinary retention is rare, and usually the incidence rate is around 3 cases per 100,000 women per year, and there is a 1 into 13 female to male incidence ratio. There are, for the etiopathogenesis, there are 4 categories. It may be obstructive, pharmacological, neurological, or psychogenic. For obstructive causes in females, usually it is due to uterine fibroids, pelvic organ prolapse, urethral diverticulae, pelvic masses, cervical or urethral cancers, urethral strictures, or it may be following anti-incontinence surgery. For pharmacological etiologies, several drug categories are indicated, commonly tricyclic antidepressants, opioid analgesics, antipsychotics, antimuscarinics, and alpha-adrenergic agonists. So Fowler syndrome, spinal cord compression, and multiple sclerosis, they are neurological causes for acute urinary retention. So the psychogenic causes we can diagnose after excluding all of the above etiological factors. So the initial management is bladder catheterization because it's diagnostic as well as therapeutic. So depending on the situation, we can go for either urethral or suprapubic catheterization. And the definitive management of acute urinary retention depends on the etiological factors. So surgical treatment is usually indicated for obstructive etiologies. For pharmacological etiologies, we can discontinue the drug or we can use alternative drugs. And for neurological causes, for spinal cord decompression, we can go for spinal surgery. Otherwise, there is a place for neuromodulation as well as clean intermittent self-catheterization. Behavior therapy is helpful for psychogenic causes. So in chronic urinary retention, usually the etiological factors are the detrusor underactivity, bladder outflow tract obstruction, and or it may be the combination of detrusor underactivity and bladder outflow tract obstruction. In bladder outflow tract obstruction also it may be due to anatomical obstruction or the functional obstruction. Functional obstruction can be further classified into dysfunctional voiding, detrusor sphincter dyskinesia, and primary bladder neck obstruction. So in evaluating patients with chronic urinary retention, history and examination is very helpful. So after history and examination, confirmation of chronic urinary retention can be done by either bladder ultrasound scan, and when bladder ultrasound scan is not possible, we can go for catheterization after voiding. According to the AUA guidelines, if the patient fulfills criteria for the diagnosis of chronic urinary retention, they indicate serum creatinine as well as renal ultrasound scan. To exclude associated urinary tract infection, we can go for UFR and urine culture. So after doing these basic investigations to identify or to differentiate the dysfunctional detrusor underactivity from bladder outflow tract obstruction, we can go for urodynamic evaluation. So in the urodynamic evaluation, if the diagnosis is bladder outflow tract obstruction, it needs further evaluation to exclude anatomical causes, for which we can go for cystourethropy, and to exclude other functional causes, we can go for electromyography or the video urodynamic studies. So chronic urinary retention treatment, it depends on the etiological factors. For detrusor underactivity, we can go for clean intermittent self-catheterization, or there is a place for sacral neuromodulation. So anatomical obstructions, it needs surgical interventions depend on the etiology. So dysfunctional voiding is initially treated with pelvic floor muscle rehabilitation, and if it is not responding to pelvic floor exercise, then we can go for trial of selective alpha-1 blockers. Commonly used one is the tamsulosin. So even after this treatment, if the dysfunctional voiding is refractory, then other drug groups like amitriptyline, benzodiazepines, baclofen, and tolterodine can be used, and there is a place for botulinum toxin injection as well as the sacral neuromodulation. In detrusor sphincter dyskinesia, there is no optimal treatment up to now, but the available treatment options like botulinum toxin injection and bladder neck incision, they also has limited success rates. Primary bladder neck obstruction primarily treat with clean intermittent self-catheterization, or if not responding, we can go for selective alpha-1 blockers. And if the patient is not responding to this first-line treatment, then there is a place for bladder neck incision as a second-line treatment. So I will move to my second topic, female urethral diverticulum. So it's a urine-filled periurethral cystic structure within the confines of the pelvic fascia. As you can see in this picture, it's usually present as a midline anterior vaginal wall cystic swelling. Usually, the condition is common in the 3rd to 5th decades of life with the incidence of 1 to 6%. And recently, there is the increasing in incidence because of the improved detection rates. Usually, it can arise from any part of the urethra, but commonly from the mid-urethra. Usually, they are single, but in 10% of cases, they may be multiple. The majority of cases are acquired, and the most accepted hypothesis is the infection and obstruction of the periurethral gland. So, in addition to this obstruction of an infection of the periurethral gland, so other theories include mechanical trauma during vaginal delivery, previous urethral or vaginal surgery, or repeated urethral instrumentation. Morphological wise, there are 3 types. Where simple urethral diverticulum, which is an isolated cystic structure which connects with the urethra with a single ostium. And when the urethral diverticulum partially encircles the urethra, it is called horseshoe or saddleback type urethral diverticulum. And when it is circumferentially cover the urethra, it is called circumferential urethral diverticulum. So there are several clinical presentations that can mimic presentation of the urethral diverticulum, like Skinny's gland cyst, Gardner's duct cyst, vaginal wall inclusion cyst, vaginal leiomyomas. Likewise, there's a long list of cases which can mimic urethral diverticulum. So urethral diverticulum, it also has several complications. So for example, 5% of cases, they may be associated with malignancy. And in 4 to 10% of cases, there may be stone formation within the urethral diverticulum. And if the diverticulum ruptures, the patient may present with a fistula. And there are reported cases of endometriosis within the diverticulum as well. So usually these patients present with variety of presentations. 20% of patients are asymptomatic, and 23% they classically present with dysuria, postvoidal dribbling, and dyspareunia. So in addition to these symptoms, there are other voiding symptoms and storage symptoms, and the patient may present with urinary incontinence, vaginal masses, and hematuria. And some patients, they may have features suggestive of overactive bladder or stress urinary incontinence. During physical examination, 80% of cases, there is a midline anterior vaginal wall mass. In 40% of cases, you can observe urethral discharge on gentle pressure on the cystic structure. So investigation-wise, as baseline investigations, we can use bladder diary, and for exclusion of urinary tract infection, we can go for urinalysis as well as the urine culture. And in urethral pressure flowmetry, we will be able to see classical biphasic recording. And to exclude other concomitant bladder pathologies, we can go for cystourethroskopy. And if the patient is having significant voiding symptoms as well as in urinary incontinence, then there is a place for twin channel urodynamics. So in imaging wise, ultrasound scan, we can observe anechoic or hypoechoic lesions, and there is a 95% sensitivity in micturition cystourethropy, as you can see in this picture. Even though the double balloon high pressure urethropy is having 90% sensitivity, it is nowadays not considered because of its invasiveness. And out of these investigations, MRI is the gold standard investigation with a sensitivity of 100% sensitivity. So as you can see in this picture, in the T2 weighted images, the urethral diverticulum, it will appear as a hyperdense structure. So the treatment, it is having non-operative management as well as operative management. For asymptomatic patients, those who are refusing the surgery, as well as patients those are not suitable for surgery, we can go for non-operative management, where we will do counseling, specifically about the carcinoma risk, as well as there's a place for prophylactic antibiotics and behavioral changes like the digital stripping of the anterior vaginal wall after maturation, because it will prevent postvoidal deeply, as well as it will reduce the recurrent urinary tract infections associated with stasis of urine within the diverticulum. So for symptomatic patients, there is a place for operative management where we dissect and where we do dissection and excision of the diverticulum. So if the diverticulum is small and situated in distal urethra, then we can, in those cases, we can go for marsupialization. So if the condition is coexistent with stress urinary continence, the usual approach is first we treat the urethral diverticulum, and after later on we can assess the continence status of the patient, and if it's indicated, we can go for anti-incontinence surgery. So the outcome of the surgery, even with primary surgery alone, it has 80%, 89% success rate. But when we take into holistic approach, even the primary surgery as well as the redo surgery, it has a 70 to 97% success rate. The surgical intervention is associated with several complications, commonly the urinary tract infections, incontinence, and recurrence. And there may be uretrovaginal fistula formation. So in summary, when we consider female urinary retention, acute urinary retention is rare in females, but when we are evaluating patients for chronic urinary retention, we need to do urodynamic studies for proper diagnosis and treatment. So female urethral diverticulum commonly originates from mid urethra, and the commonest theory which explains the etiology is the infection and obstruction of the periurethral glands, and there is a risk of malignancy. It's around 5%, and MRI is the gold standard investigations, and the surgical excision has a high success rate. Thank you very much.
Thank you, Milan. Milan, you said there's a risk of malignancy. What is the common histology? It's adenocarcinoma. And the second question, you show the picture of MRI images. They are T1 images or T2 images?
T2 images.
So what's the color of water in T2 images?
It's whitish in color.
Right, thank you. Well done. Now, Nandasena sir, if you get urethral caruncle, how will you manage, sir? Do we have to excise it?
I give some estrogen for a while, that it will settle most of the time. Okay. And there is risk. I mean, sometimes these lumps sometimes are a bit suspicious sometimes. In that case, I go for a biopsy as well. If it doesn't respond, topical estrogens.
Right.
I also agree with that. But I use topical steroid and antibiotic cream. Almost never do a surgical excision because it invariably you are going to remove the mucosa and cause stenosis. And as Nande says, you get very rarely huge masses. You know, you are not sure whether it's a malignancy, although you clinically think it's a caruncle. The fear is there in the back of your mind. So in such situations, I would do a sort of incision biopsy-like thing so that mucosa is not removed in excess. And treat with steroid cream, yes, estrogen cream also, it's possible. It invariably works. Even with severe bleeding cases, they respond to antibiotics and local application of estrogen or steroid.
Thank you, sir. Arul sir, have you seen females coming with high pressure chronic retention with normal size urethra?
Yeah, we have. I think Dr. Sirosha Gunawardana reported the first case, and we also have seen few. We do female bladder neck incision, which is done at the 12 o'clock position. This I learned from my boss.
So what is the reason, sir? Is it bladder neck sclerosis?
Don't know. Thing is, Gobi, we don't do urodynamics, so we really, I can't tell you exactly what the etiology is. It may be these various dyssynergias, isn't it? What Milan was telling, sphincter dyssynergia, because when you do the cystoscope, you don't see any stenosis or fibrosis. But in about 60%, the bladder neck incision works.
Milan, you said about Fowler syndrome. Milan,
yes, sir. Yes, sir.
What is the basic pathology behind the Fowler syndrome? What is the pathophysiology?
It is the increase in external urethral
activity.
Activities. Yes.
So tell me one important investigation to conclude the diagnosis. You said increase electrical activity or activity
Yes,
of the
electromyography.
very good, so EMG. Can you tell me what is a well-recognized treatment for Fowler syndrome? You said it. You said it. I think sacral modulation, isn't it, to relax the sphincter? Yeah. Any other questions to experts regarding all the topics today?
There are two things I want to regarding acute retention in these females. One is where they, from clinical point of view, it's better to classify these because the etiology varies depending on the age of the patient. So it's maybe pre-menarche, during childbearing age group, and post-menarche. Etiology is very different. Remember that hematocolpos is a one cause of acute retention in female before menarche. That I have come across few patients, females coming with acute retention. Other thing is young patients who are coming with acute retention. Examine the lower limbs, reflexes, and things. I have come across 1 or 2 cases where the patient came with acute retention, and later on it turned out to be a transverse myelitis. There are no symptoms at the first presentation. It's the acute retention, no other symptoms. But later they get lower limb symptoms, some neurological symptoms. So examine the lower limbs, reflexes, everything very carefully in these patients. Those are two important things, I think.
Yeah, good point.
And so the postmenopausal women, they come with the recurrent urinary retention, and you are doing a urethral dilatation. How many times you have to do urethral dilatation, or do you want to reconstruct the urethra by doing a vaginal flaps?
Yeah.
So always doing UD.
I haven't. Anurudha, can you answer the question? I don't. This a female urethral dilation. I don't like very much.
It causes more scarring actually, but we have no option. But I think, can you remember? I think it was Julian Shah.
Julian Shah, yes. He said there were two
vaginal flaps, no? They do.
Yes. That's a very nice operation. Thing is, Suranga, what has happened is we see much less postmenopausal urethral stenosis now. Probably, I don't know the reason, but the cases where we see this female urinary retention in the elderly, that is above 50 years, as Nande said, I classify it as 0 to 15, 15 to 50, and above 50 years. We get away with a female BNI now. Most of them have been sorted out, Suranga. Therefore, I didn't get a chance to do a flap. Actually, I was waiting to do that because after listening to Julian Shah, I think I have that video even of doing it. But if you get a case, I think you should try that. This repeat urethral dilatation is not a good thing. It causes more scarring, as Nanda says. I completely agree with him. And our women are not very good in learning CIC also.
Yeah. And so some people come with during pregnancy, they develop urinary retention.
Yes, first
and
trimester.
sometimes they develop after the delivery, they develop retention. How to manage those things, and what's the reason, sir?
During pregnancy, you tell them to sleep prone, isn't it? Or something like that. Or it's only during the first trimester. So it's really bad cases. You put a catheter and remove after 12 weeks and they are okay. Once the gravid uterus come out of the pelvis. Postpartum, yes, because probably due to the stress on the pelvic nerves, you can get a little bit of detrusor hypokinesia and retention. Occasionally we see. What I do is, I don't know whether this is correct. I keep them on a catheter for 4 weeks and I remove it. And during that, just before 48 hours before removing the catheter, I start them on tamsulosin and remove the catheter. But I don't continue tamsulosin on a long-term basis because they are breastfeeding also. But I remove the catheter. Rarely, some of them may go into retention again, and then you recatheterize, and after another 4 weeks, when they are due for catheter change, I do a trial and see. Extremely rare You may go beyond 2 months, but I haven't encountered anyone. So I keep it for 3-4 weeks and do a trial. Yeah.
Other thing is when you are removing urethral diverticulum, it's not a very, sometimes it's not a very easy thing. Now, if you get a defect following surgery, what can you do?
Yeah.
Because that has happened to me.
Yeah.
When you excise the diverticulum, there's a defect, and when you
yeah.
close, there's a severe narrowing of the urethra. What can you do at this stage?
I'm not very sure, Nande. What I do is I anticipate the problem and I leave a little bit of the. It's actually a cyst-like thing, isn't it? When you really do the surgery, diverticulum is like a cyst. So when I'm close to the urethra, I leave a little bit of that wall and use that to repair the urethral defect, the wall of the diverticulum itself, you know.
Sometimes they are very difficult to identify the limits of excision. Sometimes with edematous, there is some sort of infection, whole edematous and scars sometimes. So you have to have a catheter always.
Always, yes. I also have entered the urethra, but I haven't encountered such a big defect because I don't excise much tissues close to the urethra. I leave some tissues, Nande, so that I can use that to sort of buttress the urethra. It may not be the best urethral tissues, but at least because otherwise I can't think of any way of repairing it, no? Unless you bring a flap or something.
Yeah, I have done 2 cases. I have put a pubovaginal sling. It responds very well.
Yes, okay.
One of the advantages of this pubovaginal sling, the autologous sling, so you can just put underneath the defect and it does a good job. I have 2 patients. They are continent as well, and they are passing urine, and their urethra is normal almost.
That's a good idea.
So sling can be used to reconstruct the urethra in this sort of situation.
So, can we use anterior vaginal wall as a kind of a rotation or a flap to reconstruct?
Yeah. I think but I haven't done anything that sort of surgery, but I have done this and avoids problems.
Yeah. I just would like to tell few words about incontinence. I think what you said, I think Nalin did a good presentation. But in real clinical practice, patients with urinary incontinence, you don't get this black and white picture. You know, in young people, you might get stress incontinence where you go from one step to the other until you put a sling or dynamic sling, like Nande says, and it's very clear cut. But the majority of patients with urinary incontinence are elderly, disabled, they come in wheelchairs, they have large number of comorbidities, and so the true population of urinary incontinence is like that. It's not a black and white picture you get. In such situations, my practical approach is, first thing is, I want to find out whether it's really a problem to them. Some of them, very elderly women, they have mild incontinence. They come actually out of fear of having a cancer. Or they are brought by their children because their children and grandchildren are worried that because of this little urine leak, these small children in the house will get infections or some fear. So, in those cases, I tell them, those such risks are not there. I ensure that there is no cancer. There is reassure the family, extended family, that you don't have to worry. Then most of the time, the incontinence that is left thereafter, real incontinence itself is not a major problem. Most of them are adjusted to that little leak with wearing 1 or 2 pads at home, or they don't wear pads or keep some piece of cloth. Most of them come from poor backgrounds and they're quite adjusted to it. And they wear a pad only when they visit the temple or something like that. So in such situations, I think it is not a wise thing to offer them major operations and try to correct that mild incontinence without identify the exact underlying anxieties they have. So it is very important to take a good history and look at the bigger picture of the problem they have. And most of these cases can be managed with very little changes in lifestyle. And second thing is patients with urinary incontinence. This is not about these young people, you know, very active life, don't have much comorbidities where you can really treat. But the others, I tell them that they have to be realistic also when they seek treatment, because I may not be able to make them completely dry. I always tell that, and I tell them, okay, I'll give some medicines or offer some operations, but it may not give you 100% dryness. It is part of your aging body also, you will have to accept. So that this is my approach. I don't know whether this is correct. Some of you may not agree, but after 25 years of urology, this is something I have learned about urinary incontinence. And most of the cases, when you take a good history, spend some time with them, you don't have to do many tests. And most of the time, you can make a reasonably sound diagnosis and offer some form of practical management plan. That's all. Thank you.
Thank you, sir. That was very informative and very helpful. Any other questions to expert from the audience? In the absence of question, I think we have passed more than 2 hours and 15 minutes. Taha and Dr. Suranga, over to you.
Dr. Kalana is here? Okay, fine. With that, we come to the conclusion of Uromet 8. Today we have discussed very, infrequent, rarely met conditions. First of all, I would like to thank SLAUS and the educational committee, and then the experts, Anuruddha sir, Nandasena sir, and Manjula sir. They have shared their knowledge and experience, which were very useful to the trainees and young urologists. Then the trainees who have done excellent presentation, Dr. Nalin, Dr. Tiline, Dr. Gihan, Dr. Achudan, as well as Dr. Milan. They have taught us well. And then the moderator, Dr. Suranga, Dr. Nishant, and Dr. Gobi. And at last, not the least, the SIPLA, who is their sponsor, always, helping urology, post-Laos. Thanks goes to them also. With that, we will wind up today's session, and we will update you regarding the next Uromet. Thank you very much. Have a good night and a nice weekend.
Thank you. Good night.
Thank you.